We're on Module H, the digestive system. Our digestive system is also known as our gastrointestinal system or the GI system. It extends from the mouth to the anus and has two functions, digestion and elimination. We also have, or we can break down the digestive system into the upper GI structures, lower GI structures, and accessory structures. Our upper GI structures include the mouth, pharynx, esophagus, and stomach. Our lower GI structures include the small intestines and the large intestines. Accessory structures include our teeth, tongue, salivary glands, liver, gallbladder, and pancreas. And our GI system is responsible for digesting food, absorbing nutrients, and eliminating waste. So one term you want to be familiar with is peristalsis. This is the involuntary contractions that move food through the digestive system. And this is going to be important because as we age, I'm jumping ahead a little bit here, but as we age, we know our body systems just kind of in general slow down. This goes as well for peristalsis. So if the food moving through our body and our GI system slows down, this is what causes constipation to be much more likely in the older adult. So just something to keep in mind. You may see abbreviated in charting a BM, stands for bowel movement. A bowel movement is simply the passage of stool or bowel elimination. You may hear it called defecation. It involves the movement of the feces from the large intestines and out the body. When a normal bowel movement should be semi-solid material. It is made of water, solid waste, bacteria, and mucus. The number of bowel movements is going to be dependent on that person, so it's kind of unique to each individual. But something to remember is that if you have a resident who has not had a bowel movement in 3 days, it is definitely something you want to make sure the nurse is aware of, okay? Iron supplements, something to keep in mind. Iron supplements can cause a dark black color in the stool. Some red foods or red food colorings can cause a red color. Sometimes the diarrhea, which of course is liquid stool, constipation, which is the inability to have a stool, or infrequent, difficult stools, sometimes painful. Flatulence is just gas. Incontinence of stool is not being able to control our bowels. When everything is functioning properly, we have an adequate intake of a well-balanced diet of food and fluids. Like I mentioned, we pass soft brown formed stool, tubular in shape, without pain. We expect a non-distended abdomen and active bowel sounds. As we age, some of the changes that do occur in our GI system is the decrease in number of taste buds, that slowing of peristalsis that I talked about, slower absorption of nutrients, digestion takes longer and is less efficient, the lining of our stomach thins, our bowel muscle and sphincter muscles tones or lose some tone. Oh, I skipped ahead too many, sorry. Decrease in saliva production, which can cause difficulty in chewing and swallowing. Decrease in the amount of digestive enzymes as well. Decrease in appetite, sometimes loss of teeth. Our taste and smell do become slightly altered. And protein, vitamins, and minerals are just not absorbed as well. Now, going to the next slide that I jumped ahead to. When we see these variations from normal, we want to make sure to report them. Difficulty swallowing or chewing, poor intake of diet and fluids, significant weight gain or loss, loss of appetite, abdominal pain or cramping. If we notice that the stool has any blood, pus, mucus, or other discharge in it, and in that case, don't flush it because the nurse is going to need to see it. Or incontinence. If your resident, you see them or they complain of nausea and vomiting, heartburn, diarrhea, constipation, pain with bowel movements, or that whitish, black, or red color stool as well. Again, this may in some cases be related to supplements like iron or foods like beets, but never go on that assumption. Always let the nurse take a look to evaluate that. All right, let's talk about some of the common issues we may see in the digestive system. We've got gastric ulcers and gastritis. Gastric ulcers, also called peptic ulcers, are raw sores in the stomach caused by excessive acid secretion. People who have gastric or peptic ulcers are going to have burning pain 1 to 3 hours after eating. They're going to be belching probably regularly. Sometimes there's vomiting. It can cause bleeding that results in that black tarry stool that we just talked about a second ago. The nurse aide's role is to report any abnormal stools to the nurse and encourage residents to provide whatever diet has been prescribed to them, because they're going to want to avoid certain foods when they have ulcers. Gastritis is the inflammation of the lining of the stomach. There are certain risk factors that put us at higher risk of having gastritis. This would be use of certain pain relievers, older adults in general, because if you recall, we just mentioned how as we age, the lining of our stomach tends to thin, so we're more at risk for gastritis, excessive alcohol use, and stress. You may have heard of ulcerative colitis. This is a chronic inflammatory disease of the large intestine. It is a serious condition that can result in a colostomy. A colostomy is a surgically created opening called a stoma through the abdomen that goes directly into the large intestine and allows stool to be expelled into a bag that's affixed to the abdomen. You've probably heard of gastroesophageal reflux disease, or maybe heard of it referred to as GERD. GERD is a chronic condition when liquid contents of the stomach back up into the esophagus. This is it's acidic, it's inflammatory, and can really damage the lining of the esophagus over time. Heartburn is the most common symptom, and it's caused by the weakening of the sphincter muscle that joins the esophagus to the stomach. If GERD is untreated, it can cause ulcers and ulceration. So if someone has a history of GERD, we want to make sure that we are following the care plan, making sure in particular with these residents that they're eating their last meal of the day, even earlier than we might for some residents, right? So about 3 to 4 hours before bedtime, and they should remain upright for about 2 to 3 hours after eating each meal. We want to provide extra pillows to keep that head of bed up and follow any dietary modifications. The reason for keeping them upright and eating before going to bed is because that lying down or leaning back really can encourage and exacerbate that reflux, that GERD. We've talked about constipation a bit already, but this is when the stool moves too slowly through the intestines. You may see abdominal swelling, gas, irritability, of course, reports of not having a bowel movement. This can result from either decreased fluid intake, poor diet, being inactive, certain medications, aging, certain diseases, and sometimes it's just a matter of not taking the time to have a bowel movement. And this could unfortunately be because in the nursing home, if residents feel rushed to hurry up to get to the bathroom if they need assistance or something, for example. So we never want to rush our residents when they're going to the bathroom, whether it be to void, to pee, or to defecate. Fecal impaction. This is hard stool that is stuck in the rectum and cannot be expelled. This results in an ongoing constipation. So if someone has not had stool for several days, if they have abdominal swelling or distension and pain in the rectum, this is a sign that there may be fecal impaction. Sometimes you'll also see oozing of liquid stool around, or it's coming out. Don't mistake that for a bowel movement. A lot of times if there is a true fecal impaction and constipation, some liquid stool will make its way around. That is not a bowel movement. Nurse aides are not allowed to remove fecal impactions. Depending on the facility where you go, and you may be trained as a nurse aide to do enemas, to administer enemas, but it is not part of your basic nurse aide 1 training, so do not do it unless you've been trained by your facility. An enema is when a specific amount of water that may or may not have an additive is inserted into the colon to stimulate and facilitate the passage of stool or a bowel movement. So the doctor is going to write an order for what type of enema they want and the amount of fluid. There are different types, like I mentioned. There's tap water, soap suds, saline, and commercially prepared enemas. So some general rules when we're dealing with the digestive tract and our rule as nurse aides, some additional things to keep in mind. Make sure dentures are in place, right? So that's going to help our residents to be able to chew, be independent, not choke or aspirate. Observe for choking, especially if there's a history of trouble with swallowing or chewing. Make sure that your resident has fluids with every meal, and often offering, if you're assisting someone, offer a bite of food followed by a drink of fluid, then a bite of food, then a drink of fluid, etc. We want to encourage those daily bowel movements and not rush our residents. We always need to keep our residents with incontinence, whether it be fecal incontinence or urine, clean and dry, and follow infection prevention, which is wiping from front to back. We want to assist residents with keeping themselves clean as well, like washing hands. Provide privacy for elimination. Again, this will also help to make our residents not feel rushed or interrupted. We want to encourage plenty of fluids and fiber in the diet, as these will encourage regular elimination patterns. In addition, regular physical activity can be really beneficial to elimination. So it's really important to encourage this and assist with this as needed. And understand that bowel habits are going to be different for each individual resident. If we can determine kind of that resident's regular bowel habits, that's ideal. So they may prefer to go at a certain time of day, for example. And if we can support that, then that's going to be really helpful. Keep in mind that the ideal position for elimination is in a leaning forward squatted position. If a resident cannot get out of bed, we want to assist with getting as close to this position as possible by having the resident sit up in bed, so they can use those muscles and actually contract those muscles and let gravity help aid in elimination. And that concludes the digestive system.